to start another important medical disorder in the pregnancy. It is the heart disease in the pregnancy. So the heart disease in the pregnancy, though it is not too much common as compared to the diabetes mellitus and anemia, but still it is not the incidence is not a lower. Nowadays the incidence is increasing. Rather, the 1% of the pregnancies will be complicated by the heart disease. The incidence is decreasing in the developed countries while it is more in the developing countries. There is some change in the incidence of the heart disease in the developed as well as the developing countries. The incidence is decreasing in the developed countries due to the well-developed healthcare system. उनका healthcare system तो इतना अच्छा है क्योंकि antenatal care में भी चीजें diagnose हो जाती हैं and treated earlier. So because of the well-developed and because of the modification in the surgical treatment and the diagnostic modalities of the in the healthcare system, though there is the heart disease which are common in the developed countries, and that heart disease are the congenital heart disease. But these congenital heart disease are the corrected congenital heart disease. They are diagnosed earlier and they are corrected earlier in the childhood period. So the female with the corrected cardiac heart disease like mitral stenosis, stenosis, aortic stenosis, VSD, ASD, they are present in the pregnancy and they have the successful pregnancy. While in our circumstances, as we are belong to the poor countries, these surgeries are very costly and they require the expertise. So though we have the expertise, but the surgeries are very costly. So not every person can have such type of the surgery. But we have the more common rheumatic heart disease, the lesion of the cardiac diseases are the lesion like mitral stenosis, mitral regurgitation, and other the lesion which are occur because of the rheumatic disease are more common. But even because of the invention of this penicillin, prophylactic use of the penicillin, there is also decreasing the incidence of the rheumatic heart disease. Now, it is very important that you must have the review regarding the what are the physiological changes which occur in the pregnancy, as we discussed earlier in the few lectures. So there is a change in the plasma volume. There is a 40 to 50% increase in the plasma volume. As we discussed in the anemia in the pregnancy, that the plasma volume is increased by the RBC count is relatively not so much increase as compared to the plasma volume. So the volume load is increased on the heart. So there is an increase 40 to 50% increase in the plasma volume. There is a 43 to 50% increase in the cardiac output. The heart rate will also be increased 10 to 15%, while there is a decrease in the mean arterial pressure. It's a 4% decrease in the mean arterial pressure, while the stroke volume will be increased to 27%, and there is a decreased systemic vascular resistance. Now, if there is a decreased vascular resistance, then that means there will be the decreased blood pressure. So there will be the vasodilatation, vascular system resistance will be decreased. There will be the hypotension, particularly in the early pregnancy. The pulmonary vascular resistance is also decreased up to the 34%. So this is important to start or to understand the cardiac diseases in the pregnancy, what changes occur in the normal physiological. Now these changes which start from right from the 6 weeks of the pregnancy. 6 हफ्ते से ये changes start हो जाती हैं and then will be increasing progressively and slowly up to the 2nd trimester, and at the end of the 2nd trimester or the early 2nd trimester there becomes a plateau. There will be the no increase or there will be the no change, but some changes may occur in the labor as well as in the postpartum period. Symptoms of the pregnancy which are mimic to the cardiac disease. ये भी बहुत ही important है कि आपको पता होना चाहिए कि pregnant patient में क्या-क्या चीजें हो रही हैं normally, and these symptoms are mimic to the cardiac disease like the shortness of breath, breathlessness जो है वो this is also common because of जो respiratory changes हो रही हैं उसकी वजह से. There may be the tachycardia as we discussed 10 to 15%, 10 to 15 beats per minute जो है there is a pulse rate increase हो रहा है, heart rate increase हो रहा है. Syncope feeling because of the positional भी हो सकती है, because of the hypotension. Normally there is a splitting of the first heart sound, and there may be the systolic murmur क्योंकि volume बढ़ रहा है, so there may be the pansystolic murmur. That there is a displacement of the apex beat. If you are going to palpate the apex beat, this will be slightly displaced upward to the left because of the increased size of the pregnancy. And no doubt there may be the edema, particularly the pedal edema, which is a quite common, but which is a quite common in the normal pregnancy. But this edema could occur in the cardiac disease of the pregnancy. But that edema is not specified to the dependent area like the sacral region or in the pedal edema, but it will be the generalized. If the patient has the generalized edema or the weight gain more than 0.75 or more than 0.5 kg in the late second trimester or the third trimester, that means this is significant. So it is you must understand what the normal changes occur in the pregnancy, what are the abnormal changes in the pregnancy. Now it's a very important, you must have the classification of the heart disease, what are the type of the heart disease which could occur in the pregnancy. All type of the heart disease could occur in the pregnancy as in the outside the pregnancy. So we broadly divide this heart disease into the congenital heart disease, and that congenital heart disease may be acyanotic and the cyanotic heart disease. What are the acyanotic heart disease, which is quite common as compared to the cyanotic heart disease, and that cyanotic heart disease is less compatible with the life as compared to the acyanotic, and they can be corrected easily. The patient can cope with the acyanotic heart disease as compared to the cyanotic heart disease in the pregnancy. So you must learn about what are the diseases which are common in the pregnancy. These are the congenital acyanotic heart disease like ASD, atrial septal defect, ventricular septal defect, pulmonary stenosis, and coarctation of the aorta. These are the disease which have in which there is a no cyanosis. While there are certain cyanotic heart disease, it means in these there is a no left to right shunt. There is a no left to right shunt. That's why the patient can cope with it. While in the cyanotic heart disease like Fallot statology, Eisenmenger syndrome, these are the cyanotic heart disease. Then there is a group of the disease which will lead to the different lesions. That is the rheumatic heart disease, as we discussed, because of the this rheumatic disease which involve particularly the mitral valve and the tricuspid valve and the aortic valve. So there may be the mitral stenosis, there may be the mitral stenosis, they may be converted into the mitral regurgitation, aortic stenosis, and the aortic regurgitation. Then there is a cardiomyopathies which is quite common in the pregnancy, particularly the peripartum or the postpartum cardiomyopathy. No doubt nowadays is the population aging population has been increasing, so the ischemic heart disease are quite common, has been seen in the pregnancy. Other conduction defects like may occur, the syphilitic, thyrotoxic, hypertensive disorders, that may also lead to the various variable changes in the cardiovascular system and the variable disorder in the cardiovascular system. Now, we classify the disease according to the risk. This is classified disease according to the lesion and according to the type. There are the certain disease which are the low risk, and certain disease are the medium risk, certain disease are the very high risk. The low risk means that in these the risk to the mother is 0 to 1%. Risk of the maternal mortality or risk of the maternal morbidity. And these have the atrial septal defects, the ventricular septal defect, the patent ductus arteriosus, mitral stenosis type 1 and 2, corrected failure statology. So these disease having the very low risk to the mother as well as to the fetus. While certain diseases have the medium risk, and these are the medium risk disease are the mitral stenosis type 3 and type 4. Mitral stenosis is if it is a complicated or associated with the atrial fibrillation, then it will be carry the medium risk. Aortic stenosis, again it is a uncorrected failure statology. These are the disease which have the medium risk to the mother as well as the, if there is a risk to the mother, definitely there will be the risk to the fetus as well. Then there is a high risk disease in which 25 to 50% chance of the maternal mortality. And these are the, and in these conditions, we advise, other cardiologists advise to the mother to not be pregnant, or she has a, either she has a permanent sterilization or she should not be get pregnant. And these high risk diseases are pulmonary hypertension, Eisenmenger syndrome, aortic coarctation. Aortic coarctation with valvular involvement, either aortic valve or the mitral or tricuspid involvement. Aortic coarctation, this is also one of the congenital lesion. So it may be associated, there may be the multiple congenital lesion, this may be associated with the any valvular involvement. And Marfan syndrome with the aortic dissection or aortic aneurysm. So these are the diseases in which the pregnancies are contraindicated, or if the pregnancy, if the patient get pregnant, there may be the 25 to 50% chance that she may be the have the mortality or the very severe morbidity. Now, this for understanding, this is a very important, and this should be learned to the every students or the every person. What is the New York Heart Association classification? And this has been adopted by the everyone. So what is the New York Heart Association classification? It classifies the heart disease in grade 1, 2, 3, and 4. Means mild, moderate, and severe. And how they classify? By doing certain exercise tests. So in the grade 1, or if the disease is mild, it means the patient has no limitation of the physical activity. She can perform her household activities without any problem. Means ordinary physical activity do not precipitate the dyspnea, palpitation, fatigue or angina. यानी patient can be perform, वो अपना घर का काम कर सकती है, चल सकती है, फिर सकती है, और उसमें उसको कुछ भी dyspnea भी नहीं होगी, shortness of breath नहीं होगी, palpitation नहीं होगी, fatigue नहीं होगा, angina, chest pain नहीं होगा उसको. So this, if the patient is categorized in this grade, then we call it as a grade 1 or the mild disease. Again, in the grade 2, there is a certain slight limitation of the physical activity. बहुत ज़्यादा तेज नहीं चल सकती, वो चल रही है, लेकिन ये कि फॉर एग्जाम्पल मुसलसल अगर आधे घंटे तक चल रही है तो फिर उसकी फिर उसको she will be uncomfortable. But there is a slight limitation of the physical activity, but comfortable at rest. वो थोड़ी देर बैठ जाएगी तो बेहतर हो जाएगी. Ordinary physical activity produce the symptoms like dyspnea, palpitation, fatigue, and angina. This is classified into the grade 2. Grade 3, marked limited. थोड़ा ही चलेगी तो वो उसकी सांस फूलने लगेगी. She feel the dyspnea, she feel the palpitation, she becomes fatigue, and she feel the chest pain. So the marked limitation. 2 कदम चल रही है तो उसको तकलीफ हो रही है. Less than ordinary physical activity produce the symptoms, but she again becomes comfortable at rest. अगर वो बैठ जाएगी, लेट जाएगी तो comfortable at rest. This is a grade 3. While in the grade 4, grade 4 means unable to carry out any physical activity without discomfort. Any type of that. थोड़ा सा भी उसको चलना जो है ना उसको पेन करेगा, palpitation होगी, dyspnea होगी, and the symptoms of the cardiac insufficiency attack. वो लेट भी नहीं च पाएगी, वो सीधी लेटेगी तब भी उसको प्रॉब्लम होगा. So this is a categorization of the New York, according to the New York Heart Association classification. You must classify whenever the patient come to you. You must classify in which class the patient is fit, and you will be treated accordingly. Now, what is it's a very important, you must learn that what is the effect of the pregnancy on the heart and what is the effect of the heart disease on the pregnancy. So as we discussed, what are the physiological changes, you know the physiological changes. Then once you know the physiological disease heart है, आप ये समझ लें कि heart पे burden बढ़ रहा है. हमने जैसे ये बात की, आपने देखा होगा कि ये changes जो हो रही हैं in the plasma volume, in the cardiac output, in the heart rate, ये सब changes जो हो रही हैं, these all changes will put the burden on the heart. That's why there will be the worsening the heart disease, worsening the diseases. यानी जो भी क्योंकि cardiac output बढ़ेगा तो कार्डियोमायोपैथी के भी वो मसल इतने ज्यादा काम नहीं कर पाएंगे. देयर में भी द चांसेस ऑफ द कार्डियक फेल्यूर. और देखिए कि अगर इफ देयर इज एओर्टिक स्टेनोसिस और इफ देयर इज अ माइट्रल स्टेनोसिस, तो क्या होगा कि देयर इज अ लिमिटेड, देयर इज एक पर्टिकुलर वॉल्यूम जो ब्लड का होगा वो इजेक्ट होगा, क्योंकि देयर इज अ स्टेनोज्ड वेल. So the heart cannot expel too much amount, cannot receive too much amount of the heart. But there is an increase in the volume in the pregnancy. So there will be the difficulty in coping with all these physiological changes. So the disease will be worse in the pregnancy. There may be the more chances of the congestive cardiac failure. Initially, there is a right heart failure followed by the CCF. There may be the bacterial endocarditis, particularly with the mitral stenosis, corrected mitral stenosis with the prosthetic valves or the biological valves. There is a more chances of the bacterial endocarditis. There may be the pulmonary edema as the pulmonary vascular resistance will be decreased. More chances of the pulmonary embolism, and there is a more chances of the rupture of the aneurysm, particularly the aortic aneurysm. So these are the effect of the pregnancy which occur on the heart disease. What are the effect of heart disease on the pregnancy? Pregnancy में क्या होगा? दिल जो बीमार दिल है वो pregnancy को क्या करेगी? There may be the miscarriages. Again, there will be because of the hypoxia, anoxia, and this lead to the miscarriages. Moreover, there may be chances of no doubt, the congenital heart disease in the fetus that will lead to the miscarriage. The preterm labor, this could be the iatrogenic or this could be the spontaneous. There may be the intrauterine growth retardation, again because of the hypoxia. The baby cannot receive the adequate amount of the oxygen in the blood, that's why. The congenital heart disease in the newborn. If the mother is suffering from the congenital heart disease, like VSD, like this, there may be the 5% chance that the VSD है, ASD है, maternal stenosis है, aortic stenosis है, aneurysm है, या coarctation of the aorta है, तो newborn यानी उसका जो fetus होगा, this will be suffering 5% chance होगा उस बच्चे को कि वो उसको भी similar type उसको भी heart disease हो, and 50% chance, 40 to 50% chance है कि similar type of the disorder हो. For example, अगर mother को ASD है तो 5% चांस तो है कि ऑफस्प्रिंग जो है वो सफर, लेकिन 50% उसमें चांस होगा कि बच्चे को भी ASD हो. दो देयर में भी द अदर डिजीज, बट 40 to 50% चांस है कि बच्चे को सिमिलर टाइप ऑफ द लीजन हो जो मदर को. एंड नो डाउट देयर में बी द इंट्रायूट्राइन fetal death. This is again because of the hypoxia and the anoxia. What are the high risk cardiac conditions? Like the systemic ventricular dysfunction, जिसमें ejection fraction less than 30% हो, और न्यूयॉर्क हार्ट एसोसिएशन की जो क्लासिफिकेशन 3rd या 4th में, जिनमें अब देखें ये हाई रिस्क कंडीशन वो है, इसको आप समझ लें कि जिसमें हम कहते हैं कि इट्स बेटर टू नॉट कंसीव, प्रेगनेंसी कंट्राइंडिकेटेड हो. पल्मोनरी हाइपरटेंशन, cyanotic heart disease, uncorrected cyanotic congenital heart disease. Aortic pathology, जिसमें dilated aortic root more than 4 centimeter हो, Marfan syndrome हो, ischemic heart disease हो, लेफ्ट हार्ट ऑब्स्ट्रक्टिव लीजन हो, लाइक एओर्टिक स्टेनोसिस हो, माइट्रल स्टेनोसिस जैसे मैंने अभी बात बताई, प्रोस्थेटिक हार्ट वेल्व्स जो है ना, मेटल हार्ट, इसका हम डिस्कस करेंगे, व्हाई द प्रोस्थेटिक हार्ट वेल्व में बी द हाई रिस्क कार्डियक डिजीज। एक तो इसमें बैक्टीरियल एंडोकार्डाइटिस के चांसेस बहुत ज्यादा होते हैं, and another thing which is important that all those patients who have the prosthetic heart valves, they always require the anticoagulants, and these anticoagulants may be continued throughout the life of the dead patient. Now, these anticoagulants, usually they use the oral anticoagulant like the warfarin, and these anticoagulants have the certain effect on the teratogenic effect on the fetus. So, if the mother is using the prosthetic valve, then having the prosthetic heart valve and using the anticoagulant, particularly the warfarin oral anticoagulant, we offer the patient to switch on the heparin, because the heparin do not cross the placenta and they have no teratogenic effect, while the warfarin having the teratogenic effect on the warfarin embryopathy. There is a warfarin embryopathy. उसमें एक typical phase होता है, nasal hypoplasia and other lesions occur into the fetus. So this is contraindicated into the first trimester of the, particularly the first trimester of the pregnancy. So it is advisable to switch the patient from the warfarin to the insulin. Oh, sorry, to the heparin. So that's why the warfarin is contraindicated in the, that's why the prosthetic heart valve may become into the high risk cardiac diseases. Any history of the previous pericardial cardiomyopathy, there may be the 25 to 50% chance that the patient may again suffer from the similar type of the problem in the current pregnancy if she is suffered once in the cardiomyopathy in the pregnancy. What are the risk factors which further aggravate the heart failure or the heart disease in the pregnancy? So that again, as we discuss in the diabetes mellitus, the health of the mother should be optimized prior to the pregnancy. Leon, if the patient having the leon, it should be corrected, because these risk factors should be corrected prior to the pregnancy if the patient is going to be planned her pregnancy, because these factors further aggravate the heart failure in the pregnancy. These are the respiratory infection, any type of the chronic obstructive airway disease हो या respiratory infection हो, कोई pneumonia हो, कोई और type of the respiratory lesion हो या urinary tract lesion, because this will causes the bacterial endocarditis. Any type of the infection may lead to the bacterial endocarditis, and this is a very worst condition in the pregnancy. Anemia, no doubt, already हेमोडाइल्यूशन हो रही है, फिजियोलॉजिकल एनीमिया हो रही है, और अगर उसी के साथ फर्दर इफ देयर इज अ मोर एनीमिया, एनी टाइप ऑफ द एनीमिया, particularly iron deficiency anemia या अदर एनीमिया होगा, तो दिस विल फर्दर एग्रीवेट द हार्ट फेलियर. Obesity, body mass index more than 35, use of the corticosteroids, use of the tocolytic agents, क्योंकि ये फिर अगर ही tocolytic agents again will lead to the increase the hemodynamic circulation, and then will the burden over the heart, because the tocolysis also increase the heart rate, and that will be the heart has to work a lot because of the use of this tocolysis. मल्टीपल गेस्टेशन, अब देखिए मल्टीपल गेस्टेशन वैसे ही रिस्क है, मल्टीपल गेस्टेशन में एनीमिया हो रहा है, वॉल्यूम देखें, एक मल्टीपल गेस्टेशन का मकसद है कि हर चीज को आप डबल कर दें, जो चेंजेस हो रही हैं नॉर्मली सिंगलटन प्रेगनेंसी में उसको आप डबल कर दें, तो आप सोचेंगे कितना बर्डन होगा हार्ट पे ना. तो इसी वजह से मल्टीपल गेस्टेशन आल्सो इज अ रिस्क फैक्टर फॉर द cardiac failure in the pregnancy. Hypertension, you have to correct the hypertension, you have to optimize the blood pressure of the patient prior to the pregnancy, otherwise this will again increase the chance of the heart failure. Arrhythmias, if the patient जो particularly ectopic beats वैसे common है pregnancy में, तो आप उसको mimic ना करें उसके साथ जो है ना heart disease के साथ. You must differentiate the arrhythmias from the ectopic beats. पेन रिलेटेड स्ट्रेसेस, पेशेंट को किसी भी टाइप का पेन, एनी टाइप ऑफ द पेन विल लीड टू द प्रेसिपिटेट द हार्ट फेलियर, एंड नो डाउट द फ्लूइड ओवरलोड. if any time, if you need the fluid, you must have the restricted fluid to the patient, because if you give the more, already there is a volume overload, already there is an increase in the plasma volume, and if we are going to give the more volume or more fluid to the patient, this will cause us to the heart failure, and ultimately there will be the congestive cardiac failure. Now, after this understanding all these things, what are the types, what are the assessment, the management, again, all the medical disorder are the multidisciplinary approach. This is not a function of the simple obstetrician. This involves the cardiologist, this involves the anesthetist, this involves the neonatologist, the cardiac surgeons, the cardiac special nurse who can deal with all these problems, who's a special nurse who is a trained, so she can deal with this problem. The issues in the pregnancy, in the counseling of the women with heart disease, ये बहुत ही important है. This is a very important prior to us, if the patient come to you. It's ideally, as we discuss in the diabetes mellitus, that pregnancy in the heart disease again should be the planned pregnancy. It should not be accidental. Every patient should have the pre-pregnancy assessment, and you must discuss all these issues while the patient is planning for the pregnancy. What are the problem could occur? What are the risks to the mother? So you must counsel the lady while she is going to plan for the pregnancy with the heart disease, like the risk of maternal death. There is a more chances of the maternal death, particularly the cardiomyopathy, if the patient is a ischemic heart disease, if the patient is a cardiac failure. So there is a life expectancy to mother ki hogi, that will be reduced. This is though it's a very crucial to disclose this statement or to counsel regarding this life expectancy, but you have to explain the mother that she is not able to rear her child more than few years. So this is very important. And then the decision of the mothers or that female herself, whether she is getting pregnancy or not. What are the effect of the pregnancy on the cardiac disease, as I discussed earlier? What is the risk to the fetus, like risk of the developing the congenital heart disease? 5% fetus will develop the congenital heart disease, and the 50% of the fetus having the similar type of the disorder. There may be the risk of the preterm labor and all the consequences of the preterm labor. That the baby may have the RDS, baby may have this neonatal jaundice, she may have the hypoglycemia, hypocalcemia, this hypomagnesemia, and there may be the learning difficulties. These babies at long-term risk, they may be develop the diabetes mellitus and any metabolic syndromes, and no doubt there may be the intrauterine growth retardation. All the patients with the cardiac disease, they require the more frequent visit as compared to the normal patient in the antenatal case. Sometimes she may need the hospital admission. Intensive fetal-maternal monitoring during the labor. This is very important. You must discuss the contraception. आपको उसको बताना है उसी वक्त क्या टाइप की contraception. Or the best time for the discussion of the contraception is the pregnancy, not after the pregnancy. During the antenatal period, you have to discuss at every visit that what type of the contraception you have to use, what type of the contraception are best for her, and the timing of the pregnancy. No doubt, you must time and the mode of the delivery, you must discuss with the patient. So these are the issues. In pre-pregnancy counseling, you must counsel the patient prior to achieving the pregnancy. In which patient the medical termination, once the patient is accidentally, if she get pregnant, so in which patient that termination is advisable? Termination is advisable in early pregnancy, particularly in the high risk group. जैसे मैंने बताया कि pulmonary hypertension है, किसी patient को cardiomyopathy है, Eisenmenger syndrome है, all these palpitation, this aortic aneurysm है, या grade 4 न्यू यॉर्क हार्ट एसोसिएशन क्लासिफिकेशन में पेशेंट आ रहा है, क्योंकि कंटिन्यूएशन ऑफ द प्रेगनेंसी विल एंडेंजर द लाइफ ऑफ द मदर. That's why it's a very important that she should be she should not be ideally she should not get pregnant. But once she get pregnant, the pregnancy should be terminated, because continuation of the pregnancy will be dangerous to the mother. And these conditions are the pulmonary hypertension, Marfan syndrome, coarctation of the aorta, and some very stenotic lesions also, or the patient may be in the New York Heart Association classification 4. If you're opting the termination, it's better to perform before the 8 weeks, when there is a less physiological changes which occur, because as we discussed, the peak physiological changes occur, though it is started at the 6th week, but peak occur at the end of the 2nd trimester. So it is better to perform the termination prior to the 8 weeks. Suction evacuation with a manual vacuum aspiration is a better option, because it do not require, there are small cannulas, and usually with a simple analgesia or without anesthesia, we can do the suction evacuation easily. That's why the baby is so much small, there's a small sac inside, and it is easily sucked out by the manual vacuum aspiration. Or if you are not, you have no availability of the manual vacuum aspiration, you can do the mechanical termination of the pregnancy by the insertion of the Foley's intracervical Foley's catheter and inflate the balloon with a few ml of the water. That will causes the dilatation of the cervix. That will causes the release of the prostaglandin and the spontaneous expulsion of the fetus. Medical termination, though sometimes we use the misoprostol, we can use the gamiprost, we can use the prostaglandin, but these prostaglandin are vasoconstrictor and they may lead to the risk to the mother. Now, there are the certain investigation which are the, some say that these investigation should not be performed to diagnose a disease, but there are certain investigation which can be performed in the pregnancy, but you must know what are the changes which occur in these investigations, so you may interpret properly. So in the ECG, if you are going to do the ask the patient to have the ECG, तो आपको पता होना चाहिए कि ECG में क्या physiological changes होंगे, then you can interpret properly this is the pathological changes or this is the physiological changes. Normally in the ECG there is an axis shift slightly to the left in the late pregnancy, क्योंकि horizontal position होती है ना heart की, तो left axis deviation होती है, left axis deviation होती है. There is a small Q wave and the T wave. Small Q wave होती है and there is a T wave inversion in the inferior late. Q wave small होगी, T wave inversion होगी, and these are normal. However, the T wave inversion is a sign of the ischemic heart disease. But T wave inversion in the inferior lead is not uncommon in the pregnancy. This is because of the horizontal position of the heart. Atrial and the ventricular ectopic is quite common, so you must differentiate between the ectopic beats and arrhythmias. This is a very important. Troponin is one of the indicator. Troponin जो हम use करते हैं for ischemic heart disease, it is not affected by the pregnancy, so it is a valid test for the diagnosis of the myocardial infarction. X-ray chest, though X-rays, any type of the X-rays are contraindicated in the pregnancy, but X-ray chest का जो radiation risk है ना, this is a very rare. So you can, if needed, if at any time, if you need the X-ray chest, you can be perform the X-ray chest at any time, and there is a little risk of the radiation. So with a shield, आप shield देके abdomen पे, and the patient can have the X-ray chest if needed. Then echocardiography, it's a very important. The echocardiography का क्या है कि एक तो baseline echocardiography होनी चाहिए. जब patient आपके पास आए तो आप degree of lesion, ejection fraction, cardiac function, structural functional heart status जो है ना, आपको पता होना चाहिए earlier at the 6 weeks of the pregnancy. जैसे जैसे patient आपके पास first time पे आएगी, so you must have the echocardiography, then it should be repeated 28 weeks, then 34 weeks at the time of the labor. यानी ये रिपीटेशन होती रहती है इसकी एकोकार्डियोग्राफी की, क्योंकि आपको फंक्शनल स्टेटस देखना होता है। एको इंजेक्शन फ्रैक्शन कितना है हार्ट का, और को लीनियन बढ़ तो नहीं रहा है। So the echocardiography is an important investigation in the heart disease to the pregnancy. This is to excluding, to confirming, to monitoring the structural heart disease in the pregnancy. Then the MRI, CT, these both are the investigation are the safe in the pregnancy, and you can perform this type of the investigation if needed. Angiography, if needed, it should not be withheld. For example, कोई भी patient acute coronary syndrome की आपके पास आ रही है, chest pain हो रहा है, उसको shortness of breath हो रही है, she cannot walk around, then if needed you have to diagnose, क्योंकि acute coronary syndrome को तो diagnose सिर्फ angiography से ही कर सकते हैं ना, तो you can do the angiography and even the angioplasty. If the needed, you can do the angioplasty. Same moment में जब angiography हो रही होती है, तो angioplasty भी कर सकते हैं. It's not contraindicated in the pregnancy. Now, what is the antenatal management? Antenatal management का मैंने बताया कि it is a multidisciplinary approach involving the experienced obstetrician, the cardiologist, the anesthetist, the pediatrician, or the neonatologist, and the nurse. The patient should be noticed immediately as soon as she get pregnant. वही high risk pregnancy वाली बातें होंगी कि as soon as patient get pregnant or she misses her period, she must come to her obstetrician, and the work of the obstetrician that she involve the cardiologist. She review her record, she assess her degree of the lesion, and whether this pregnancy is safer for her or not. She must have the coordination with the cardiologist, and both the cardiologist and obstetrician will decide whether she should continue the pregnancy or she should not continue pregnancy. The pregnancy should be terminated, or if the lesion, it can be corrected or not in the pregnancy. So she should, when the obstetrician, the work of the obstetrician is confirm her pregnancy by doing the ultrasound. As we discussed that the ultrasound is for the confirmation of the pregnancy, the viability, number of the pregnancy, and other problems. So the work of the obstetrician and the cardiologist assess her heart and assess the degree of the lesion, whether the lesion is corrected or not, and what type of the medication patient is like as we discussed. If the patient has the prosthetic heart valve, she will be definitely she will be on the anticoagulant, that is the oral anticoagulant warfarin. So the cardiologist switch the warfarin to the this Calaxin because it is safer to the pregnancy. But sometimes with the Calaxin there may be the chances of the hematoma formation because of this decrease the platelet count. So the switching of the drugs or the drugs which are safer in the pregnancy should be advised by the in the combination with the obstetrician and the cardiologist. Now the routine care as usual, you have to check the general, ask the patient. It's a very important to ask about the unusual symptoms. That is the any breathlessness, particularly at the night, any palpitation, any tiredness, reduction of the exercise tolerance, or any chest pain. So whether it is on the walking or so, you have to grade. You have to grade the patient in which grade of the heart, New York Heart Association patient is at this moment. So you ask about at any visit, any routine in care, you must ask the symptomatology of the patient. And that symptoms are the breathlessness, the chest pain, the palpitation, the tiredness, and exercise intolerance. And then you have to examine the patient. You have to do the body mass index of the patient, general look of the patient, whether she's anemic, she's a sinus or not. And then you must palpate the pulse, record the pulse, whether it is a normally raised or if patient has the tachycardia, whether her blood pressure is a normal or it's a raised. You must check the JVP. You must auscultate the patient for the heart sounds. as we say that the splitting of the first sound is a normal and pensystonic murmur are normal, but any additional murmur, any additional sounds, edema apart from the pedal and sacral, the generalized edema and the basal crepitations. Auscultate the chest for the basal crepitation. If there are the basal crepitations, that indicate the cardiac failure. So the any other signs of deteriorating the cardiac status should be carefully investigated, should be assessed, examined, investigated, and treated. So this is the aim of the our antenatal. Then, if the patient is everything maternal and the fetal monitoring is the reassuring. If she has a stable heart with no such type of the symptom, no added comorbidities, and no any problem, she can continue the antenatal visit in the outpatient department. But she may require more frequent visit as compared to initially she can visit every four weekly. Then she come the 2 weekly up to the 28 weeks or up to the 34. Some say that up to the 30 weeks. Some say up to the 34 weeks. So but after that, initially she had the 2 weekly up to the 28 to 30 weeks, then 15 days up to 34 weeks, and then either she's intelligent enough, she can cope with the obstetrician and cardiologist, and she's a good compliant patient, then she can manage herself in the home as well, and she can weekly. Otherwise, all the high risk patients should be hospitalized at 34 weeks of the gestation. All the high risk, all the patient with a medical problem should be hospitalized, particularly the patient with a cardiac disease should be hospitalized, and she should be monitored in the hospital. But if the patient is intelligent enough, she can come immediately if she notices any change her problem or any change in the symptoms, then she can be managed in the outpatient. It's a very important, you must ensure the drug compliance, whether the patient is taking the drugs regularly or not, like antiarrhythmic drugs, like the anticoagulant drugs, like the beta blockers. So it's a very important. You must ensure that the patient is taking drugs properly or not. Then no doubt at each visit you must monitor the fetus by the, initially the fetus is monitored by the ultrasound simply. Later on you can ask the patient whether she is feeling the fetal movements or not. You listen the fetal heart sound, you can do the ultrasound examination, you can do the fetal ECG, and no doubt the fetal biophysical profile later on after the 28 weeks of the gestation, particularly the biometric, क्योंकि IUGR जो है वो इसमें हार्ट डिजीज में इंट्रायूटेराइन ग्रोथ रिटार्डेशन के बहुत ज्यादा चांसेस होते हैं, फीटस की ग्रोथ प्रॉपर नहीं होती, तो सीरियल बायोमेट्री करनी चाहिए इन पेशेंट में. इफ यू फील एट एनी टाइम कि अमाउंट ऑफ द लाइकर कम है या ग्रोथ फीटस की आपको सही नहीं लग रही है, तो बायोमेट्री हो. बायोमेट्री इंक्लूड्स द हेड सर्कमफेरेंस, द abdominal circumference, the biparietal diameter, and the female length. So by this measurement, you can do the biometry and assess the fetal weight. Now, there are certain fetal advices, specific advices which we give to the cardiac patient particularly. The cardiac patient cannot be do the excessive work. She should have the adequate rest at the home. Undue exertion उसको बहुत ज्यादा काम नहीं करना है, इतना नहीं कि पूरा दिन वो काम करते रहे और अपने आप को थका दे. So undue exertion should be avoided. She should take adequate rest. 2-3 घंटे दिन में, रात को भी 9 बजे वो चली जाए अपने बिस्तर पे. She should avoid no smoking at any time, because that smoking will further aggravate her disease. Medication, compliance of the medication is a very important. जैसे मैंने बताया कि some patient may require antiarrhythmic drugs है, digoxin है, diuresis है, या anticoagulants है, या beta blockers है, जो भी drugs उसकी, and she should be continue their drugs. Early diagnosis and treatment of hypertension, अगर ये मैंने पहले भी बताया, if the patient, ideally she should be checked pre-pregnancy. This should be treated, hypertension, anemia, infection. All these problems should be treated prior to the pregnancy, or if the patient is not coming prior to the pregnancy, in the early pregnancy. Therapeutic prophylactic cardiac intervention is applicable. ये जैसे मैं हम लोगों ने डिस्कस किया कि prior to the pregnancy अगर कोई valvotomy है, देखिए कि therapeutic का मकसद ये कि if the patient is on the anticoagulant, जैसे मैंने बताया कि warfarin है तो you switch on the Galaxy. Any prophylactic cardiac intervention which is required, like if the patient is having the acute coronary syndrome, she can have the angiography and she can have the angioplasty. Or if there is a mitral valve stenosis, or if there is a aortic stenosis, she can have the balloon valvotomy. She can have the balloon valvotomy. Ideally, this should be occur prior to the pregnancy. But if they come to the pregnancy and the lesion is a larger, you can do it into the pregnancy as well. Benzathine penicillin, 12 lakhs at 3 weeks to prevent the recurrence of the rheumatic fever. ये पहले भी हमने discuss किया है कि benzathine penicillin reduce the chances of the rheumatic and that's why reduce the chances of the mitral stenosis and tricuspid stenosis. Diuretics, beta blocker, digitalis, if required, they should be continued in the pregnancy. They are not contraindicated in the pregnancy. Anticoagulants, surgical balloon valve, as we discussed earlier. Which patient require the hospitalization? All these patient can be done this thing in the outpatient department or the combined cardiac and this obstetric clinics. Some patient may require the hospitalization. All the cardiac patient, मैंने पहले भी बताया कि they should be hospitalized at 34 weeks of gestation. Even the patient is in the stable condition, again then any time she may have the pulmonary embolism, at any time she may go into the cardiac failure and she may have the discompensation of the cardiac status. So they should be hospitalized at 34 weeks of the gestation. Emergency admission may require if there is a deterioration of the functional grade. अगर वो functional grade न्यू आर्थराइटिस एसोसिएशन के functional grade 2 में है, अगर 3 में आ गई, 3 में है, 4 में आ गई, तो किसी भी टाइम पे आप समझें कि उसकी कंडीशन या ग्रेड deteriorate हो रहा है, she should be immediately hospitalized, or she may have the sign and the symptoms of the fever, cough, persistent cough, arrhythmias, heart rate more than 100 beats per minute, JVP raise हो गया more than 2 centimeter, patient becomes grossly anemic, or she had any type of infection, particularly the respiratory infection, the urinary tract infection, she should be hospitalized for the injectable antibiotics. She can have the anytime she has the PET, abnormal weight gain. Any abnormal weight gain, या उसी के साथ कोई other medical disorder or like thyroid disorder or any type of the other disorder, the patient may be immediately hospitalized. Then no doubt there is a management at the labor. This is a very important. Again, all the patient with the cardiac disease should be referred to the tertiary care center where the CCU facilities and ICU facilities. Coronary care unit facilities are the intensive care unit facilities are the high dependency units are available where the senior anesthetist, where the senior cardiologist and the obstetrician are available. These patients should not be delivered by this is simple unexperienced person. Always these patients require the senior obstetrician, delivery by the senior obstetrician and assessment by the senior obstetrician. Our aim is to continue the pregnancy up to the term, aim to continue the pregnancy up to, provided the fetal-maternal monitoring is reassuring. Aim of continue the pregnancy is to give the chance to the female to be having the normal vaginal delivery. It's better to avoid the induction of the labor if possible, because induction by the medical means will lead to this as we discussed, this will lead to the cardiac compensation. And you must start the prophylactic antibiotics, no doubt, to prevent the bacterial endocarditis. And as we discussed, this fluid balance, this is a very important. You must balance the fluid. Excessive fluid should not be given because this will lead to the cardiac failure. So the patient, if the patient is in the labor, she should have the either 70 to 80 ml per hour के हिसाब से. And you must ensure the adequate amount of the urine output, otherwise you can give the diuretics. The position is very important. Ask the patient to have in the proper and left lateral position. Avoid the supine position because this will lead to the hypotension. This is the supine hypotension, postural hypotension. So it should be this will lead to in the supine position. There will be the chances of the compression of the big vessel, that is the aorta and the vena cava by the gravid uterus. So there will be the supine hypotension. So these patients, all the pregnant patients, apart from the whether they are the cardiac disease or not, they should be having in the left lateral position, not in the supine position. This is advisable to all the pregnant patients to prevent the aortocaval compression. Then it's a very important, you must discuss the analgesia and anesthesia with the patient if he requires. But it's a better to give the epidural analgesia to the patient to prevent any pain, because the pain will precipitate her problem. So the anesthesia and analgesia with a senior anesthetist should be discussed at the time of the labor. It's a prior to the labor. It's a better to discuss all these things prior to the labor, as we discussed earlier in the antenatal period. So the epidural anesthesia is a better anesthesia and analgesia for these patients. However, any type of the regional anesthesia will lead to the hypotension, as well as if the patient is on the anticoagulant therapy, then there may be the chances of the hematoma formation. Then if you are going to keep the patient in the labor, monitoring the patient in the labor, our aim is that the patient should be delivered within 12 hours. Should not be, the labor should not be prolonged. And once the patient come into the second stage of the labor, the labor should be shortened. And the monitoring of the labor is by the as usual. That is, you monitor the maternal monitoring and the fetal monitoring. Maternal monitoring by the symptomatology, by checking her vitals and the general condition of the patient, and the fetal monitoring is by the continuous CTG, as we discuss in the other medical disorders. We have to shorten the second stage of the labor. The second stage should not be longer than the 2 hours. It should be shortened by either the application of the forceps or application of the vacuum, because the Valsalva maneuver is contraindicated into the patient with the cardiac disease, particularly the compensated cardiac status. Then once the patient is delivered, then the active management of the third stage of the labor. We do not advise to give any type of this drug which is contraindicated in the pregnancy, like methergine. Use the oxytocin. And oxytocin should be given, either you give in the intramuscularly as soon as the baby's shoulder is delivered, or the baby is delivered, give intramuscular oxytocin 10 international unit. Or if you are going to give in the infusion, this should be given in the small amount of that. Normally we give the 60 international unit in 500 ml of the fluid in normal patient, non-cardiac patient. But if you are going to, if you have to need to give by the infusion, it is given in the 200 or the 100 ml. So the volume should be reduced. Then no doubt it's a very important that you have to keep the patient for at least 1 to 2 hours in the labor room or the high dependency unit for the monitoring of the fourth stage of the labor. That is a stage of the observation. This is a very important because the fluid, as soon as the placenta has separated, the 500 ml of the fluid may enter into the maternal circulation. And you think that amount of the fluid which enter into the maternal circulation will be the burden on the diseased heart. So there may be the chances of the heart failure. at any time in the fourth stage, or the patient may develop at any time, or because of the tetanus uterine contraction, there may be the embolism, particularly the amniotic fluid embolism. So the fourth stage is a stage of monitoring that is very important. You have to monitor the patient in this for the symptomatology and for the vital of the patient. Patient should be carefully monitored because at any time she may develop the cardiac failure, or at any time she may develop the pulmonary embolism and the sudden death may occur. So this is very important that you must monitor the patient for 1 to 2 hours after the delivery of the fetus. What are the postnatal advices? All the patient should continue their treatment, which is started either, for example, if she is on the warfarin, she can continue the warfarin, and after the delivery, you can switch the patient from the Clexin to the warfarin. You must give the antibiotic cover because to prevent the bacterial endocarditis, all these patients should not be anemic at any time. So the iron supplementation should be continued. All the patient can have the breastfeeding, and you must discuss the contraception. What type of the contraception these patient could have? The barrier method. Ideally, these patients should have the limited family because the cardiac condition may be worsening as soon as the age get advances or the pregnancy, there's a repeated pregnancies. So the barrier method is a better one, but this is the unreliable type of the contraception. You advise the patient the effective and the reliable contraception, that is either they use the progesterone only pills, they can have the Norplant, they can have the DMPA. We cannot advise the intrauterine contraceptive because this may causes the infection, and that will again infection. If there is an infection, there may be the chances of the bacterial endocarditis, so it's not advisable. OCPs, these are the contraindicated in the cardiac diseases are better. All these patients should have the completed their family earlier, or they have the limited family, either 2 or 3 childs, or if the condition is worsening, then the 1 child is enough. Then if the permanent sterilization is required, the vasectomy is a husband. His husband is a candidate for having the vasectomy, because if the patient needs a surgery, she needs the anesthesia, that is will be dangerous for her. So this is all about the cardiac disease. If you have any question.
Ma'am, kindly tell
Okay.
the indication of the warfarin. So, can you
Yes.
explain how
Yes,
it's
yes.
contraindicated?
Warfarin is a drug which is a transfer to the placenta and causes the warfarin embryopathy. This is a teratogenic, and he has the certain structural deformity into the fetus, particularly the nasal hypoplasia and other limb deformities. So it is not advisable. Any question? Okay.
And ma'am, you have mentioned avoid supine position.
Yes.
And ma'am, you also said the avocable ma'am compression. Can you explain this, ma'am?
Yes,
I
yes.
couldn't understand.
This is occur normally even in the pregnancy. देखें कि जब pregnant mother होती है, uterus की size कितनी होती है? Uterus की size 36 weeks तक होती है ना? This, if the patient is lying in the supine position, this uterus will compress the aorta as well as the vena cava. So there is a aortocaval compression. So there will be the decreased venous return. There will be the decreased cardiac output. This will causes the hypotension and the hypoxia to the mother. That's why it is not advisable to the pregnant lady that she lie in the supine. Always we advise the pregnant lady she should lie in the left lateral position or the right lateral position. So there will be the no aortocaval compression. Moreover, in the patient with the cardiac disease, already the heart is compensated, so there may be the more chances of these problems could occur. Okay, this is clear.
Yes, ma'am. Thank you so much, ma'am.
Okay, okay, thank you.
Ma'am?
Yes, still you have the, yes. Any question? Can we stop?
मतलब वो हार्ट पेशेंट है तो
Sorry.
क्वेश्चन है
Yes.
मैम मदर जो है हार्ट पेशेंट है तो बेबी कैसे बेबी की हेल्थ पे क्या असर पड़ेगा?
मैंने बताया कि इफ द मदर इज हैविंग द कार्डियक प्रॉब्लम, ये हमने डिस्कस किया था, व्हाट आर द रिस्क टू द फीटस। आप ये रिव्यू करेंगी तो उसमें रिस्क टू द फीटस क्या है। फीटस हैव द 5% चांसेस ऑफ द, इफ द मदर हैविंग द कंजेनाइटल एनोमली, द फीटस हैव द 5% चांसेस ऑफ द कंजेनाइटल एनोमली एंड 50% हैविंग द सिमिलर टाइप ऑफ द एनोमली। ठीक है। और बाकी रिस्क जो है ना मैंने बता दिए हैं कि देयर में भी द इंट्रायूटेराइन ग्रोथ रिटार्डेशन, देयर में भी द प्री टर्म लेबर, ये भी मैंने डिस्कस कर लिया है। ठीक है। अनदर पर्सन इज वेटिंग फॉर द लेक्चर, सो आई स्टॉप माय प्रेजेंटेशन ओवर हियर। ओके, हिते ही वठंदो न डॉक्टर साहब, बस मुझे थी वो क्या जो अच्छा अच्छा